Welcome. I'm Kristen Morse. I'm the Executive Director of the Center for New York City Affairs here at the New School. We're an applied public policy research organization that's part of the Milano School. For well over a year, the city has been exploring restructuring the public hospitals system. With a new president and CEO, Mitchell Katz, about to assume the reins of the 11 hospital system, this is an appropriate time to examine where the city's system is headed and how it'll get there. We'll hear a brief presentation about the report on restructuring the New York City Health and Hospitals Corporation by James Parrott and Barbara Caress. And then we'll hear from a distinguished panel of healthcare leaders. We are honored to have an exceptional authority this morning to guide us through the discussion. It is now my pleasure to introduce our moderator, Dr. James Nickman. Dr. Nickman is the Durjan Clinical Professor at NYU Wagner School and the Director of the Health Evaluation and Analytics Program. He was previously the founding president and CEO of the New York State Health Foundation and a leader at the Robert Wood Johnson Foundation. He's published extensively on healthcare financing and improving services for vulnerable populations. Please join me in welcoming Dr. James Hickman.
So we're really looking forward to a robust discussion, and we're going to hear from some real experts, and I'm going to grill them with questions, and they're going to answer them. But what this is about today is really saying, gee, we have a real challenge in this city about figuring out how we're going to have a system that really does care for the disadvantaged, care for people at the margins who have not many options, and of course we've depended on H&H for a long time to do this, and I think we're looking at this situation where they need help. We need to figure this out. So that's the idea of this discussion, is to be forward-looking. How do we come up with ideas that we can feed back through the system? And in some ways it's precipitated, though, by this paper by Barbara and James, sort of laying out some of the issues facing H&H and sort of giving some recommendations. So we're going to start with a brief overview from them about what their paper says. But I want to emphasize, I'll say it again later, but we're not here to tear apart or pat them on the shoulders. This is not about their paper. It's really about this discussion of H&H. So the paper, I think, sets the stage and is the context.
Good morning. Anybody who's standing in the back, there are some seats up front, so please come forward. I think we have almost enough chairs for all the people here. I want to start by thanking NYSNA for, am I audible? Yes. Okay. I want to start by thanking NYSNA for supporting our work. I actually can't think of anybody else who would have done it so generously and so patiently. And the New School and NYSNA as well for supporting this forum, and of course our panelists who have agreed to take on a very, very difficult topic. So let me say a few words about our findings. When James and I started out, I fully expected to find that the system had changed profoundly from the one that I knew 40 years ago, when a friend and I co-wrote a study of HHC, and I'm having trouble with H&H, HHC in the midst of the fiscal crisis. At that time, that was 1975, and the corporation was barely 5 years old, and it was under intense pressure to downsize, to close hospitals, to give whatever was profitable or sustainable to the voluntary sector. And the president of HHC at the time, a man by the name, I don't want to go on and on, but a man by the name of Mike Holloman, who had been one of the founders of the Medical Committee for Human Rights, who was an icon in the progressive and African-American communities, said no. So at HealthPAC, we wrote an article, and in the article, we concluded the voluntary hospital model works best for private patients who use hospitals for acute inpatient care, patients whose primary medical care are met elsewhere. The prevailing hospital model does not satisfy the needs of the bulk of municipal hospital patients, and as second-class imitators of the voluntary hospital model, the municipal system produces dissatisfied patients and disgruntled workers 40 years ago. So now, I don't know a lot about the gruntles of the current workers, and although I look at Medicare Compare, I really don't know about the satisfaction of the patients, but I can say that the most surprising finding for us was that this system is quite different than the voluntary system. It's not a poor imitator, it's actually different. It takes care of, in many ways, different people, provides different services, and although there is significant overlap in the community hospital function, you know, they take care of people with serious illnesses, people who come into the ER, they provide a whole lot of services that are common in any hospital. HHC provides predominance of services to people who are, for one reason or another, and mostly that reason is financial, shunned by the private sector. And separate is fine, but separate and unequal is not. And we have a situation now where we're, to quote a famous Supreme Court decision, we have separate but unequal. HHC, I'm sorry, I should say H&H. It's difficult in any case. I can't rebrand, I've been around too long. So let me give you an illustration of this point. So about 1 in 6 patients, inpatients, is taken care of in one of H&H's 11 hospitals. But they take care of 60% of the people who are admitted with a diagnosis of schizophrenia, half of the people with severe depressive diseases, 4 in 10 people suffering from substance abuse, alcohol or drug-related illnesses. And these are all what I'm describing, the very worst reimbursed services in the system. So they're different and they get less. Which leads to the second of our findings, and actually a pretty important one. So HHC's serious financial problems are not an expense problem, they're a revenue problem. And we looked in some detail at labor expenses. We looked at comparable labor expenses between the private system and the public system, and basically concluded that they're roughly comparable. HHCs are on the bottom, pretty much on the bottom half, some of them a little bit higher. Makes sense given the difference in acuity. This was a kind of, at this point, this is counter to a lot of the prevailing wisdom in the system, and I'm not going to go into the details. We've done a report which is in the back, and anybody who wants, please take one, and if you have questions, please come to me and James afterwards. Before turning the podium over to James, I just want to discuss one more finding. While different than most of the privates, and I want to exclude the safety nets because in some ways the safety net, voluntary hospitals look very much like HHC. I want to set HHC in the context of our $100 billion plus healthcare system. HHC provides services that other people don't, and in return, those other people can make more money. This is a symbiotic relationship. It cares for the undocumented, the uninsured, the people with less lucrative illnesses. In some communities, it's the only place to go for care. It supports the largest share of Tier 1 trauma, because if you don't control the front door, you can't control who ends up in a bed. And it's the go-to place for public health emergencies from HIV to Ebola. And so it serves a very unique and important function. And as James will describe, the public system enables the privates to prosper. And as such, its strengths, and there are many, can never be fully realized, and its financial problems can never be solved independent of understanding its context and its place. We need to look at the whole health system, not just the public hospitals. And without a major reorientation of the whole system, I think our descendants are unlikely to be standing here in 40 years talking about the crisis of the public hospitals, because I firmly believe there won't be any. James?
Thanks, Barbara. I'd like to echo thanks to NISNA, the New School, and our expert moderator and panelist. I want to extend a few of the remarks that Barbara made. In undertaking this report, we set out to better understand the roots of the financial challenges facing the city's public hospital system. In policy analysis, as in medicine, a correct diagnosis is essential if treatment is to have any chance of being effective. We knew that H&H faces a funding shortfall of $1.8 billion in 2020, even though the city has tremendously increased its level of annual support. And this revenue shortfall, which amounts to a quarter of the operating expenses, was before factoring in any possible adverse developments on the federal budget front or radical steps to undermine the ACA, which never seemed to stop coming. When we started, it appeared to us that the city was headed toward a significant downsizing of H&H, even though it was talking about, appropriately, restructuring to provide better primary health care services to the city's vulnerable communities. What seemed to be missing from the analysis, however, was any accounting for how changes in the city's private hospital system had been affecting the cost side of the ledger for H&H. We also recognize that it's long overdue for H&H to adapt to the myriad changes taking place, including changes in healthcare treatment, approaches placing greater emphasis on primary and outpatient care, and changes in health insurance, public and private. The private hospital system has certainly been adapting rapidly, with many consolidations and changes that profoundly affect their cost structures. Private hospitals have been taking a growing share of Medicaid patients, particularly those cases where the reimbursements are better. While the number of uninsured overall has been falling, H&H has been taking a growing share of the uninsured. H&H accounted for about 20% of all inpatient discharges citywide in 2014, the latest year that the data is available for. But it had 50% of all uninsured inpatient discharges and 80% of all uninsured hospital clinic visits. And as Barbara's noted, the large private hospitals have become more adept at making sure that poorly reimbursed inpatient services like psych and substance abuse disorders are provided by Health and Hospitals. Health and Hospitals is also now providing much of the costly level 1 trauma capacity. In the starkest terms, the private system has been shifting cost to the public system. 10 years ago, there were widespread concerns about the financial viability of the entire hospital system in New York City. That picture has changed dramatically in recent years. The privates have flourished, and partly that's because the public system is there to absorb costs that the private system doesn't. It's not surprising then that the net revenues for the 5 large private networks have soared in recent years. Together, they had surpluses of $877 million in 2016, up by a third, a little more than a third actually, from the year before, precisely at a time when H&H has faced recurring and mounting losses. The voluntaries have also long enjoyed a tax-exempt charitable status based on the principle of providing significant amounts of charity care and community-oriented public health services. In addition to the federal, state, and local exemption from corporate income taxes, New York City provided nearly $700 million in property tax exemptions to private hospitals in FY17, about a third greater than the amount in 2011, even though many of them occupy some of the most valuable real estate in Manhattan, and some have been acquiring even more. Private hospitals also benefit from tax-exempt bond financing through the New York State Dormitory Authority. Finally, the disproportionate share hospital allocation formula still provides an unduly large share to the privates, given their shrinking role in providing charity care. Despite their charitable tax exemption status, the large privates compensate their executives almost as if they worked on Wall Street. The 5 networks in 2015 had 108 executives who were paid more than $1 million each, for an average compensation of $2.2 million. In closing, there's no question that health and hospitals should be restructured in a way that puts it on a sound financial footing without diminishing healthcare services to the poor. The city needs a public health system that reflects and responds to low-income and vulnerable New Yorkers through a newly created community-based care network while maintaining a geographically dispersed community hospital network. We need to think about how it is best funded in the context of a $100 billion local healthcare system, how the state and the city can best act to enable that, and how the private and the public systems should work better together to serve all New Yorkers. Otherwise, far too many New Yorkers will fall through the cracks. Now, I'd like to turn it back to Jim. Thank you.
Okay, so that was great, but putting some ideas and facts on the table. And so, again, I think what we want to focus on is this question of, we have a problem at H&H, how do we handle that? And I think everybody would agree that just ongoing bleeding is not the solution. We have to do something proactive and make this work. And more broadly, this whole question of how do we make sure we have a health system that takes care of the most needy people in our city, which is the broader question and the broader goal here, I think, of all of this. So we're really lucky to have a great panel, which I'll invite you guys to. Are you going to stay there, or each come up, right? Yeah. There's these chairs, I think, for something. And we're really pleased to have, I think this panel, sort of these folks have been around. They know the public hospital system, but they know the New York healthcare system more broadly. So I think they're really, they come from different perspectives, so we're really pleased to have them. I'm not going to do their long bios, but just to mention Dr. Lillian Barrios Paoli, who has been around the city, has done aging and healthcare, the whole side of it. She's been deputy mayor. She's been chairman of the board of H&H, and just has had this incredibly rich career being at the table to make our system work. She's right now a senior advisor to the president of Hunter College. We have Jeff Kraut. Jeff has been around for a long time, really understands the New York. He was your student. That's true. That's good. So he hasn't been around that long. But he does know the system.
I just look old.
He's the executive vice president for strategy and analytics at Northwell and is one of the real strategic thinkers in this state. He's also the associate dean of the new medical school, the Donald and Barbara Zucker School of Medicine at Hofstra and Northwell. And he chairs the Public Health and Health Planning Council. So we're really pleased to have Jeff here. And of course, he works at a voluntary hospital. And then we have Andy Cohen, who's the vice president of New York City Health and Hospitals. Andy, of course, also has a set of rich experiences. She was senior vice president of the United Hospital Fund. She worked in the mayor's office. She's worked at H&H previously and has even done consulting out there and worked doing analytics. So really pleased to have you. And Andy deals with this every day in her position, worrying about strategy. Anne Beauvais is she's been the just stepped down from being president of the New York State Nurses Association. Again, she really understands the state. She understands the labor issues facing both the health and hospitals and the hospital system more broadly. So, and that's 70% of the action is labor. So that's very important, and we want to hear that. And I think I did the whole panel. Great. So let me start. I'm going to start with a setting the stage question. I'm going to ask each panelist, we'll go across this way, to answer. And sort of the, the report, which you've all read, it really lays out a dire picture, more dire than typical. H&H always has a challenge, but this seems like a very dire moment. I guess I wanted to say, does anybody disagree with that assessment? Is this, or how do you frame it? I mean sort of, how do you see the situation? So maybe just some comments.
No, I think that the report is totally in the money. I think that H&H is in a really, really difficult moment, and if they continue to do what they've been doing and change nothing, I don't think they will survive. I agree with Barbara on that. I think that the challenge is how do they reinvent themselves, and what do they start to do differently, and how do you sort of change the paradigm so they can survive, which I think it's a very important thing.
I've been working for New York City Health and Hospitals for 40 years, so there's somewhat of a connection there. But I think there's also a distancing of the public and the community at large. When you look at people that are disadvantaged, you have to look at the concept of disadvantaged. When I first started at Bellevue, I saw the immigrant population from Ellis Island, and Medicare and Medicaid was not the gold card it is today. Subsequently, patients bypassed other private facilities that were in very close proximity to Bellevue and were not treated or stabilized. They just came to Bellevue straight. We needed a federal law to fix that. Then AIDS happened, and people lost their insurance. And there was also certain disadvantages in terms of, inequities afforded those patients. We once again needed a law to fix that. When you look at all the crises that's happened within public health, it's always been the public sector that's had to deal with it, and it's within a costly framework. And it's always been the government has had to come in and back up the system. So I think that, yes, there needs to be a reevaluation, but I do believe that we need to look at what's out there from a governmental framework that we need to get there to support that system. And one of those things is a safety net legislation that would adequately support the funding that needs to be done for those people that need the care in terms of providing the actual funding for the hospitals, the agencies that provide the services.
So first, I really want to thank, the authors of the report. I want to thank NICE. I want to thank the New School for taking on this topic, which I wish I could say it was not dire. It is dire in such a thoughtful and nuanced way. The situation is dire, and I want to just sort of reframe a little bit when you talk about what's dire for health and hospitals. Really, if you are a New Yorker, health and hospitals is us. It's over 1 million patients for whom the situation might be dire. It's nearly 50,000 employees and affiliated employees. It is every one of us who is a potential patient of health and hospitals. If you get a dread disease from overseas that is a first time in the United States, if you are a burn victim, if you are a trauma victim, if you are nearby one of our emergency rooms, which serves a disproportionate number of people. So if you are a New Yorker, this is you. And if you are a taxpayer, this is you too. So I wanna reframe. The dire isn't for an health and hospitals. This is really dire for all of us. I think it's important to say that a lot of this work was done, and the mayor's report was done before we had a different administration in Washington. While it's been great, the defense of the Affordable Care Act and other healthcare spending that's managed to avoid disaster so far, I am really, and we are really afraid of what's going to come out of Washington. I will say I know from my own time in Washington, especially with Medicaid, which is our major payer, so much damage can be done without congressional action regulatorily. And I am expecting that now that some of the legislative issues maybe are paused for a moment, although some are not, the concerns about a much more activated regulatory agenda that could be incredibly damaging beyond the economics that we've talked about so far is really a huge threat. I do have to make one additional comment, though, about the diagnosis, which again, I think it is a dire situation. I want to be hopeful with respect to outcomes. I do think that we have a really substantial revenue problem and a potential risk, a definite loss in revenues from a variety of sources and many more risks. I think that we constantly have to be looking at cost issues as well, and I don't want to get into, you've done some incredibly good and nuanced work looking at benchmarks. There are innumerable benchmarks that you could apply to health and hospitals spending. In our view, many of them directionally show us that we have work to do in becoming more efficient. You've identified some that say we're doing pretty well. But in any event, it is the responsible thing to be constantly looking for opportunities to provide the services that are needed in an efficient way. And we cannot ignore that part of the equation as well. So I just wanted to make that point.
Yeah.
So let me, without being repetitive to some degree, let's reframe it. What is the role of government in healthcare? I mean, what is the role of New York City? You take a look at the New York City Charter, and it has an absolute responsibility of the city to take care of the poor and the indigent of the citizens of the city. And, Barbara referred to Wollman and some of the remarks. I pulled out an old report as well. And just, because of the lack of a cogent community policy with regard to hospitals, the relationship between municipal and other hospitals has not been definitively established. There is, however, a need for a definitive understanding as to the division of service between the two groups of hospitals and of a competent directive, or at least an advisory body, that's going to mold and supervise the future development of these two systems. Written 92 years ago in 1925. Okay? So this is a problem about the role of the municipal hospitals, the payment for those hospitals, and the private voluntary systems. We have been talking about this for 100 years. 100 years. We still haven't figured out a solution. I think that the thinking that has created the problems, the way we're funding it, that thinking has to be completely revised. You have to take all the funding streams. You have to take HICRA. You're going to have to take DISH. You have to take supplemental funding. You have to put all the rules that created those funds, and you got to put them aside, and you now got to rethink what is it we want to do with that money, and what's the best way and what's fair to do it. So the reimbursement, as you heard, if you're at 70, 80, 90% government payers, and by the way, if you're advocating for increased government payers, this is only going to exacerbate the problems. And the institutions that are doing well are going to all be in that same big, but we'll come back to that later. They cannot sustain themselves. It is economically impossible to run a contemporary institution. And when I talk about hospitals, let's talk about a healthcare delivery system. It's a generic. We'll redefine the blue H later. You can't do that without supplemental support. Interfaith hospital, $200 million of revenue, $60 million problem. No different than H&H, except for the number of zeros. That's the only difference. It's the same problems. So we have to figure out a new definition of who and what the essential safety net providers are for those communities. You have to be clear about that. They have to be paid differently. It's pure and simple. There is no solution to just marginalize and play with this. And you have to expect accountability. You have to spend a cost efficiency. You have to have expectations about restructuring. This is not a management problem, although there's opportunities to improve management. You can't balance this on the back of a workforce, although there are rules that have to be revisited on how that workforce is deployed and used. So that's the issue. And by pitting two parts of the system against each other to whatever the scraps are on the table is not part of the solution. You have to rethink the reimbursement for the safety nets. There's just no other way to get at that.
Very good. That's a great opening. So, so now I'm going to ask individual questions, but we want this to be a conversation. So if other panelists have something to add to one of the responses, that's great. And then we'll go around. And we are going to save the last half hour for questions from the audience. Looking around the audience, I can see we have lots of people who are knowledgeable, and I'm sure we'll have something to say. So we'll get to that, and we'll have time to do that too. So Lillian, let me start with you. You've been there. It's sort of, in some ways, I think that H&H, we think, surely has to take care of its core constituencies, the people who most need them, that have been laid out. I mean, can you see a path for how they can focus on those folks and focus their resources there and yet survive in the current system of how we finance healthcare?
Well, I think that that's the problem. The current system, how we finance healthcare. I think that in the current system, no, they can't. And I think that that's why you have to sort of revisit how do you finance the whole thing. I think we also have to think about how do we look at healthcare as part of an essential right that people have to it, as opposed to something that, you can pick and choose and get or not get. Nobody questions why we subsidize the educational system. It's what we do. Nobody questions, basic benefits that people get when they need them. So I think we have to look at healthcare as an essential right that people have, and how do they access that healthcare, and how do we subsidize it, or how do we finance it? It should not be a make money industry, and it's turned out to be that. And I think that that's part of the problem we have. It shouldn't be a place where people go to, an industry to make money. And I think that's the basic problem. I think that if the health and hospital system were to disappear, the voluntary hospital system would be very, very stressed. Because they would have to serve people they're not serving now. They would have to do things very differently, and they would begin to have a lot of economical problems themselves. So it's a mutual benefit. Fixing H&H is a mutual benefit thing with a voluntary sector, but we have to approach it very differently. I do think healthcare is an essential right, and we have to look at it not as a profit-making place.
I was going to ask you another question, Ann, unless you want to respond to that. But let me ask. So I think that again, labor is a big part of what goes on in a hospital. Thankfully, since it's good jobs many times. And I guess it's interesting. I spent some time at Kaiser in California recently, and it's amazing how they're rethinking what an ambulatory care visit is, how you do things, sort of, using telephone and email and, just sort of different types of people to take care of different types of needs and segmenting, and, you get dizzy listening to them. But they really are transforming the way they think about labor and the way they think about getting services done. And I guess my question, Ann, is just sort of, should we be rethinking nursing and other parts of the core delivery in our health and hospital system, and especially given the special needs of the population? Do we need different bands of who does what and all of that?
Well, I think, first of all, what's really important is you need to look at what the services are that need to be provided. In the 40 years of my practice, what I did 40 years ago is very different than what I do today, in terms of what I have available, in terms of monitoring, with regards to treatment modalities, etc. So in regards to looking at the services, then subsequently you can figure out within the scope of practice as to who can do those particular tasks, and in regards to what we have available to us in terms of communication that can facilitate patient as well as direct community education. And in saying that, there's legislation out there that we've been trying to get passed in New York State with regards to looking at safe staffing. And that would then make the idea of staffing levels, particularly related to nursing, but I think social work is also included in that regard, outlined so that we have the appropriate resources to then provide those services. It has been successful in California. They have had better patient outcomes and better returns in terms of services provided, and subsequently, it would be a very good framework to base upon. In regards to, healthcare is ever changing. What was who was considered critical when I remember starting in the ICU back when I started to today, it's very different. The technology is different. Also, what people go home with is very different. So we have to continually assess, continually look at the services, but we can't shortchange it, and we have to make sure that the people are prepared to take those services on. You can't, for example, the idea of telemetry monitoring. You can't just have a telemetry technician with a one-day course sit in front of monitors to assess, and that actually happens. I'm not making that up, all right? I am really not making that up. I mean, there are things happening out there that need to be challenged, and I can't overemphasize the fact that people have, the community at large, people, disassociate themselves with the public sector. But if you don't have the public sector, you don't have a healthcare system, period. And all of us, as my colleagues on the panel have stated, is that we're all, have to have those services available to us because at some point we may have to use them. And, I just think, the first cardiac cath was done at Bellevue Hospital, the oldest public hospital in the nation. So advancement of therapies, Jonas Salk and polio. I mean, the idea of the vaccine, the idea of looking at services provided and then subsequently look at the training that needs to go along with it and making sure the person with the right scope of practice is there to facilitate the care, and we're not shortchanging anyone in that process. And I can't overemphasize, I do believe healthcare is a right and not a privilege. And, it's not a business. It's not a commodity to be bought. Who's going to stand at that door of that hospital and say, you can come in and then you can't? That's not acceptable. I mean, I saw that happen. And we needed a federal law, EMTALA, to stop it. I never, ever, ever want to see that again. But that's the direction we're walking into right now, running into. Thank you. And just one correction, I wasn't the past president of NISNA. I was the past president of New York City Health and Hospitals Executive Council, which is 9,000 members of the 37,000 members. And I'm still secretary to the board of directors. Thank you.
Thank you. Okay, so Andy, I was teasingly going to give her a choice of either telling what the strategy of the New York Giants should be, or what should the strategy of health and hospitals be, and she could choose which was an easier thing to answer. But we're gonna force her to stay on health and hospitals. So I think the question is what we want you to be optimistic. We're very pleased that you said that opening up. But sort of what do you see as the strategy for survival, and sort of what is happening from your perspective at the perch you're at now?
I hope I will do a better job with the question about the strategy for health and hospitals and the strategy for the Giants, although Jeff just told me it'd be really easy to take the Giants question because the answer is change the coach. I don't actually know who the coach is, don't tell my kids that, but.
Well, I think we have changed the head of the health and hospitals.
Well, we are changing the coach, although.
Several times.
If I may just say some words about our current coach, Stan Brezanoff, who's really just been a fantastic interim leader who I really am grateful to have spent this year with, and he is fantastic. But we are also very excited for the arrival of Mitchell Katz from Los Angeles. I think I want to say this. Everyone who I work with at health and hospitals and everyone who I speak to in the mayor's office and otherwise is crystal clear that the mission of health and hospitals is sacrosanct. The goal is to be, that the patient need is the North Star. That need changes, but the patient need is the North Star. Survival to address the patient need and financial sustainability is a critical enabler. The actual strategies and tactics and other things, we have to be open to different approaches to that. And I appreciate your comments and so much about how medicine has changed so much and healthcare has changed so much over the last 40 years. But exactly, the frame gets bigger and bigger and makes us more aware of what the challenge really is. So the challenge is healthcare, but the challenge is actually really health, right? And so now our frame for what health in hospitals has to be effective at addressing includes things that can't be taken care of in an ICU, but need to be taken care of like longitudinally in someone's life, in addressing chronic disease, in addressing mental illness and substance abuse issues, which it is incredible to me how much just sort of the conventional wisdom about what healthcare needs to address has changed, but Health in Hospitals has been doing that piece of it and is the dominant player in that space for so long, not well reimbursed for it, but is the dominant player. So I think the challenges, or our frame on the challenges and what Health in Hospitals needs to do, keeps getting bigger. And I guess I can answer this question in an easy way, I believe, and I think the Health in Hospitals leadership and City Hall leadership believes that we need to continue focusing on the strategic sort of aim of addressing patient need, which means increasing the work that we do in the communities, increasing what we can do in the outpatient setting, and through primary care, through behavioral health integration, and just sort of more advanced treatment and management opportunities in that arena. And the specifics that people tend to really focus on of exactly like what's the location of a facility or your exact footprint, those are the things that we need to be open to addressing, clear-eyed and otherwise. I know that Mitchell Katz will come in with new ideas, and he should, and we're really looking forward to hearing them. But our North Star is the patient need. The patient need is not everywhere in our city. There are some neighborhoods and locations that are more underserved than others. We can identify those. We need to focus in those areas, and we really need to focus. That's what a public hospital system is all about. It's what makes our job so hard. We've got to look for the gaps, and we have to be there to address patient need in those areas. That can be gaps in populations who are served. It can be gaps in geography. It can be gaps in services. That's what we will keep doing. And the specifics of through which doorway, or what location, or whether it's telemetry or a face-to-face visit, those are the things that we have to adapt around and figure out what the best strategy is for today, and it might be different in 2 years, and it might be different 2 years after that.
So, Andy, let me just ask a follow-up. You focus mostly on services and medical care needs, and yet the mayor, surely, when he talks about these things, cares a lot about well-being of the most disadvantaged and health, not just, sort of gets at the population health, social determinants. And Dr. Katz has a history of being concerned about these issues in Los Angeles. So, I worry that H&H needs to play a leadership role in that whole population health sphere, and how do you make room for that when you're struggling with ICUs and getting people ambulatory care?
I don't know, Jim, how do we do that? It's a great question, and that is an ever-present conversation at Health and Hospitals, and I think it's one of the most exciting things that's happened in sort of policy conversations in the last 5 years. Again, this frame is opening to say it's not just about access to healthcare services, it's about outcomes, health of populations, et cetera. And you and I have had this conversation in a couple different forums. Health and hospitals can't do everything that's necessary to keep New Yorkers healthy, right? It takes housing, it takes the environment, it takes all sorts of things. The key, so health and hospitals can't take on all of those challenges, but it has to be aware of all of those challenges and where it can leverage something that it has in its employees, in its access to people at vulnerable moments of change. You know, somebody comes to an emergency room, that's sometimes a great place to intervene in their life circumstances, because often they're there because you can no longer ignore what is a challenge or a problem. There are many things that health and hospitals can leverage to address those other things. Mental health and is probably really at the top of that list and is high on our agenda. On the other hand, I think it is fair to say there are things that have to be done outside fundamentally health and hospitals is a healthcare provider, and there are things that have to be done outside that system that will have tremendous impact on our patients. We should be an advocate for those things, but we may not be able to actually address them all. We probably shouldn't be building and managing housing at a large scale. We should absolutely be looking for opportunities to manage and support, and where possible, finance or supplement the financing for housing for patients who have high healthcare needs or repeat visitors to the hospital and could live a very different life trajectory if they had housing.
What has been my experience is I've seen the flexibility of the staff. The flexibility of the staff to rise to the occasion of acute situations, disaster situations, and everyday situations. One of the things that's always been a bug for me of recent years is the fact that Bellevue Hospital moved close to 700 patients without incident within a 36-hour period, and the public really doesn't know that. It was neonatal babies were moved. It was all levels of patients. We moved out, and then within 3 months, we moved back in. And still were there to provide the services at the level that we were able to prior to Sandy. I think that idea of flexibility and engagement of the staff, and true engagement of the staff, but engagement of the staff concurrent with engagement of the community. Because if you don't bring the community in, the community that you serve, then you're a silo. And what purpose are you serving? So in terms of looking at that community assessment, then working with the community, working with the staff and the line staff in terms of operationalizing what those needs need to be, subsequently will bring a healthier community at large. The idea of working with other services, the idea of housing and bridging that, but that's also where we can outreach with regards to bringing some of the primary care services that need to be done for the community to those areas. Our child health clinics are very much a prize for us in terms of New York City Health and Hospitals, and it outreaches to the community. There's other primary care clinics, treatment and diagnostic centers that are part of New York City Health and Hospitals that does that. But I think the flexibility of the staff, engagement of the staff, concurrent with engagement of the community is what's going to help to move us forward. And true engagement of the community, where there is a sit-down, subsequently to look at what needs need to be done and how best you're going to operationalize it within that community we serve.
I think if you make a great point. So much work happens every single day at health and hospitals in addressing the social needs of our patients. Sometimes it's systematic and part of a program. Often it is just the drive to help of our employees. I think our goal is to make that more systematic, organized in a way that can maximally have impact, so it's not just one person trying really, really hard, but not knowing where to go or what services, can be accessed. So we need to systematize, we need to do it efficiently, and we really need to think about what our leverage points are. And I think we are doing that, because the frame, again, is much bigger. We need to have an impact on health, not just was the procedure done successfully. We all know that.
So we have to deal with three important topics before we open it up to the whole audience, and those are about how can the voluntary hospitals help, what is the role of state government? What is the role of city government? How do we, I won't even talk about the federal government today,
Well, the one thing, I just got to jump in here, is that safety net legislation. And make sure that the safety net legislation, the governor gets a clear message that that needs to be passed. And in that safety net legislation is a formula that outlines how the money should be appropriately distributed. Subsequently, the money has to follow the patient. Right now, there's a little trouble with that. Just like the money has to follow the student, it has to follow the patient. And this safety net legislation that the governor vetoed by not, just letting it die on his desk is not acceptable. We need to make sure that the governor knows and understands that this is vital legislation that needs to be passed, so that the funds are there so that we can operationalize a healthcare system that's functional. And without the public sector, the voluntary sector, the private sector cannot exist. All right, and I mean, like I said, in the 40 years I've worked there, I've seen AIDS, I've seen Ebola, I've seen anthrax, I've seen, the whole litany in terms of, cardiovascular issues that, predominated, diabetes, chronic illnesses. The idea of the cost behind it, once it becomes too costly, subsequently that patient population then moves into the public sector that carries it. But the safety net legislation has to get passed, because without the money, we're not, there's a lot of altruism in this room, but, you got to have a few dollars here and there to get it working, all right?
Okay, so
Thank you.
We can talk more about that too, and there's other issues. But Jeff, let me start with you and say, in some ways, the report puts the voluntary system on the spot here, saying they should play a role. And you made the nice point of saying it should be constructive and not just.
Yeah.
But what are some ideas of how the Big Five could help
Sure.
H&H?
I just think just the language you're using is just factually incorrect. To say that they are not helping and suggest they have to help is erroneous. You take a look at the data. Just take a look at data here. 35% of all the behavioral health and mental health issues that are inpatient are taken care of in H&H, 65% are done by the other hospitals, okay? Take a look at Staten Island. Where's the H&H hospital in Staten Island? Oh, it's me, right? It's Staten Island University Hospital. It's Richmond University Hospital. We've not, to think that the hospitals have not done a share of it. Can they do more? Yes. But to sit here and say they've not done enough is not necessarily the issue here. And it's very counterproductive to trying to find a solution to bring them in here. The second issue, if you take a look at some of the other statements that have been made, you're dealing with problems that are historic, and there is this also anachronistic, they're bad and this is good, right? So you refer to people stopping at the door that created EMTALA. Did that happen? Absolutely. Does it happen now? Absolutely not. Now, does it happen as much as it happened before? Yeah, I'm sure you'll find a case here and there. Part of it is proximity, because of how hospitals are next to each other where that opportunity presents itself. But by and large, for institutions, to anybody to suggest we stay at the door and say, don't come here and go down the block, is absolutely erroneous, particularly in today's environment where the majority of our patients are government payer patients. We have a responsibility, and I would speak for almost all of the health systems, and they're not academic medical centers. We also have this mindset going back to the affiliation agreements with H&H that have created a lot of animus and distrust, and it's made it very, very hard to constructively figure out how to do things together. It's interesting, again, when I'm obviously a history of health policy. When the corporation was founded in the 70s, the intent was to put all of the municipal hospitals under private management. That was the intent. Can you do that today? Absolutely not. Can you live without the municipal hospital system? Absolutely. I don't think you can. And you certainly can't go from where we are today to nothing. That's just not realistic, because it has to be evolutionary. So what can they do? And I think, putting aside, if you want to take responsibilities, if you want to take the expertise, infrastructure, and have that shared with the hospitals, then you have to create a new type of partnership arrangements. If you want to seek them to participate in those solutions, and it also means freeing up resources that are currently going here. So maybe we don't need as many hospitals. Maybe we have to trade it in for some of the technology and the ambulatory care networks, just as all of the private institutions have evolved, where they've been changing the nature of what's been happening since the majority of care is moving outside the walls of the hospital. They've been changing the bed supply, where the resources are spent, and the economics. The problem is H&H does not have the flexibility to do a lot of the things to keep pace with the changes in healthcare. There's political constraints, there's practical constraints, there's financial constraints. But I think as an organization, I'm speaking for my own organization, we absolutely understand our responsibility to the communities we serve. We've invested in hospitals that would have been closed had it not been for our involvement. Absolutely closed and not been here. We went into St. Vincent's. When St. Vincent's was closed, and that could be an entire different session, okay? Given where I am, the last time I was down here, the spears came. But you go over and see what we built, a hospital without beds, okay? And we finally got acknowledgement by the community that was opposing us. We had a session last week where they were basically saying, we were mistaken. This is good. This is positive. And actually, there was an article in this week's Westview News that talks to that, right, and who was one of our most vocal critics, who has come around and changed his perspective. So having said that, there are absolute ways we can do it. We can do it through partnerships. We can do it through expanding, I think the safety, the financing. And I'll just want to comment on the other 2 points before you go to questions. A lot of the hospitals get paid on the complexity of the patients that were served. H&H in particular, more so I think than any of the other institutions, need to also get reimbursed on the social, they need not a CMI, they need an SDI. Right. They need a social determinants index. To deal with the most vexing problems, of just dealing with behavioral health issues, and compounded by it being homelessness. It takes different resources, different payment rates, interfaith. I'll use them again just because I'm familiar with the study we did. About 60% of all the behavioral health patients at Interfaith are homeless. You can't expect on an average CMI, as low as reimbursement is, to deal with those problems effectively. And that's why you do have to recognize the nature of the population you're taking care of, and it's not only making adjustments for those that are overly dependent on Medicaid, it's also acknowledging the social complexity of what we're dealing, and the policy objective also should be, as the governor laid out last year, a health in all policies. That's the issue here. In the city, when we're looking at developing housing, or we're doing subsidized housing in particular, all of those projects should be coordinated with H&H. So if you should get a zoning bonus, not because you're doing something in a school or this. What about if you were to give the first floor space over to H&H to do a primary care clinic? And you should get a bonus for helping H&H evolve its model and build out into the community as part of a housing policy. We should look at how we're spending all of our social service dollars and see how is that connected to the infrastructure of H&H. So it's not disparate investments. There's a coordinated health policy framework to make that, to do that. And lastly, remind everybody, the healthcare industry is one of the largest employers universally in New York State. I am the largest private employer in the state of New York. I have 62,000 employees. That's basically, I have responsibility for over 200,000 citizens of New York. And so the well-being of all the elements of our industry, it should be really important, not only because of the health care we provide, but we are a unique economic force, and in many places, particularly outside of Manhattan, we are the economic foundation and anchor of a lot of communities. And that shouldn't be left out of the conversation as well.
Other, William, weigh in?
I guess in terms of what I'm concerned about is standard of application of policy. There was an article in one of the major papers in about the last 2 or 3 years that spoke about the cost of a colonoscopy as done at Lincoln Hospital and the cost of it in a South Jersey hospital. And Lincoln Hospital, using the same resources, meaning the same procedure, the same type of personnel, et cetera, did it much less costly than the hospital in South Jersey. Now, the point in case that I'm trying to make is that, you know, there has to be an equal spread in terms of finances. And I guess the word that really disturbs me is we're not an industry, we're a service to be delivered. And the access to care and the idea of the right to that access to care is paramount. You know, and I guess it's, you know, I grew up in Southeast Queens. I got hit by a car in Southeast Queens. They took me, the closest hospital was in Nassau County, all right? If I got hit by a car in that same spot in Queens, that trip wouldn't have been 20 minutes. Now that trip would be 45 minutes. And I was a head trauma. So, like, what would have happened? Would have I survived? So the point is access to care is paramount. And the idea of making sure that we spend our dollars efficiently and appropriately. And when we look at the, you know, and I guess I take certain concerns with regards to, when I look at cardiology, for example, New York City Health and Hospitals provides, at Bellevue, I know, because I can speak to it for 40 years, exemplary care. That cath lab I would go to, sit on that table, and I would say, whatever was done, that could have been done, and hopefully, you know, I have enough anatomy that's still workable, you know. But the point being is that, you know, there is high quality patient care, current to today's practice. And I think that instead of taking, we have to truly, that word collaborative really has to be collaborative. Standards have to be set, and outsourcing resources, you know, we have to make sure that the standards that we outsource to, if that happens, is up to snuff in terms of what we provided. And, you know, I think the idea of collaborative, making sure that we focus on it being a right, not a privilege, not a business, not an industry, is paramount. And that's what the public system is here for. And,
So
you know,
just
that's
wanna
it.
I just want to give the other two a
Yeah.
chance to talk about state, local, voluntary, and then I want to open it up. So.
I think that the role of the local and the state government is really to do a planning for healthcare delivery for the system as a whole, taking the voluntary and the public sector and create an integrated planning system. I think the problem is that it just happens. There's no overall architecture to the whole thing, and I think that that's really, really important if we're going to evolve and make everybody viable. But I do think resources have to be shared very differently, and I think that that's, that is something that is really, really fundamental to the whole question.
And then Andy, and then we're going to, if people have questions, start to come up to the mics.
I'm actually just going to parrot, pardon my phrase, the authors of the study, and I think they said it so well. Health and hospitals provide some services that are provided in the private sector as well, but it does some things that are just very different. And the things that it does that are just very different, the trauma care, the burn care, the mental health, the substance use disorder treatment, the and a number of other things. These are the things that are extremely poorly reimbursed, and the populations that are served. Your call for an SDI, I love it. I had actually meant to mention that earlier. It's really important. So I think one, it is easier to talk about pots of supplemental money and how they are allocated, and that's kind of the patchwork that we have today. But truly, if you take a look in the way that the authors of this study have at what's not paid for appropriately and look at how much of that stuff is what health and hospitals kind of bread and butter work is, I think that is a really important opportunity as we pull the frame back and think about what is health overall and not just a sort of procedure-oriented approach.
And if you believe in the social determinants, make sure you fill out those Z codes,
That's true.
because without
Yeah.
the documentation, we're not going to be able to
That's right.
get there.
Questions?
Yes.
You should tell us who you are.
I'm sorry.
We all know you, but not everybody
Can we
does.
use the mics just because we have a live stream audience that will not hear? The room will hear, but folks online won't. Thank you.
I'm Rhonda Cuddlechuk. I worked at Health and Hospital, it was then called Health and Hospitals Corporation, for 13 years. I have a pretty good understanding of the dynamics. Worked at Primary Care Development Corporation most recently and retired from there. So the configuration of health services and how we pay for it today, in other words, that which is responsible for the configuration, is a direct one-to-one reflection of a power structure, of a power configuration that benefits from and determines how things are paid for. So my question is, I don't see how we get change unless there is change afoot in the way that power is configured. And the power has very largely resided in the combination of the voluntary hospitals plus SEIU as a political machine. And I take into account also the relationship between the mayor and the governor. So I'd really like you to speak to, do you see opportunities for change in that power configuration? And if so, how?
We should keep answers brief so we let other people ask questions.
Right, and let me say, I don't believe that polarization gets us anywhere. On the other hand, I don't believe we get anywhere without examining that.
Anybody first?
I'll just reiterate safety net legislation. The idea of the safety net legislation with a formal allocation equation so that monies will be distributed accordingly. You need a pattern, you need a process, and you need to have that enforced.
Right.
Yeah,
Jeff?
yeah, but to put pressure on the governor to say, sign this.
So even in the best of economic environments, that's a daunting thing. It's made harder because of uncertainty now, because both the governor and the mayor, the uncertainty of what's happening in Washington and the ability to know if you're going to have a surplus which you can invest in restructuring or change. I think you're right. And I think with any, we have constituent politics, we have stakeholder politics here, you know, that are kind of obvious. So like everything else, there's a give and a get. And you have to figure out what may, you know, you gotta deal, to say you can ignore that dynamic, I think, would be just intellectually interesting and saying, what could we do? But the issue is, here we are, could we create a common vision of what we want to get to? And then the issue is, okay, now here is all the levers, here's the pots of money, what can we do? And everybody's going to sit there with a scorecard, I'm up or I'm down. And it's like anything else. It's a negotiation. It's very political. And can it be done? We've seen it done with some other issues. Is it done perfectly? Never. Is it going to be done like people want it to do, that really produces the optimal, most beneficial outcome? No. But we got to move away from where we are now. So I think that, you know, the environment has to be correct to do that. So it either happens in times of amazing surpluses or a crisis. And, you know, the saying is, let's not ruin a good crisis. You know, you use crisis creates opportunity at some fashion.
Okay, so we have 8 people want to ask questions. We might not be able to answer all of them, but the questions and comments, we'll get them and we'll answer some of them
And we'll
briefly.
try to keep our answers very brief.
Yes, exactly.
Hi, I'm Claudia Calhoun. I'm the Director of Health Policy at the New York Immigration Coalition, and this is a really wonderful panel. My question relates to something that Anne asked about or mentioned, which was the fact the incredible response after Sandy and the fact that people don't really know that story. A couple years ago, Errol Lewis had a op-ed which revealed that he didn't actually really understand how H&H services worked, but it got all sorts of play, and it really sort of misrepresented the idea of the revenue versus cost question and how H&H works. So my question that I'm thinking about a lot is, how do we change that narrative broadly? All the voluntary hospitals have big, massive advertising campaigns that sort of tell a story about what kind of patient experience they have when they go there. Is that an avenue that H&H can undertake to sort of change the public's imagination? And also, how do we get electeds to understand how H&H works and the values that are sort of laid out in the report? Thank you.
Let's let Andy do 2 seconds on this.
It's a great question. I think I come back to my original point that H&H is us. We're not going to have a giant marketing and advertising budget. I think you would all have a problem with us if we did. On the other hand, we need our ambassadors and our advocates and people who believe in us in the community and our employees and our, New York family to spread the word about what we do. The intricacies of how we're financed, the craziness of the patchwork of our funding sources, some people really need to know and understand that, and probably not all the ones that need to do. On the other hand, the big picture, which is that we are essential. Many people rely on us. Many people rely on us for a time and then go on, but we may help them get to the next level where they have more options with respect to their health care. They may come back to us. Other things, these are the kind of stories and understandings that we need to communicate better. And honestly, we can do what we can do with our communication staff, but this is about the advocates who care about our future.
Yes.
Thank you.
Hi, I'm sure it sounds overwhelming, all these things, and what can you do? So I'm going to give you one thing to do to get your pencils out. The legislation that Ann talked about is A 7763 and S 5661. It was passed for 2 times in the legislature, bipartisan, and we need the governor to sign it, and the governor's phone number, you can call him, you can tweet him, you can email him, but his phone number is 518-474-8390. That is a start. We're talking about funding. We're talking about changing the way funding happens. So to get the safety net legislation signed and redistribute funding in a fair way is the first step.
Thank you.
Hi,
That's all right. This side first.
I just have a comment.
That's all right.
Okay, we talk about what we need and what change. What we need, okay, healthcare is changing. I agree, it's changing. But still, we need staffing and adequate staffing that we can serve the community, the patients, with quality care. 25 patients to 1 PCA is not quality care. I have been there. I was a PCA. I started out as a PCA. And in order for us to hold on to our community and the patients that we already have and encourage others to come, we need to give the care, quality care. That's what we need, and they will come back.
Thank you.
Hi. My name is Ralph Palladino. I'm from Clerical Administrative Local 1549, District Council 37, 38 years working at Bellevue Hospital. And I'm also a patient at Bellevue Hospital by choice. It's a public health system, and the public health system in this city runs on an overhead of 2 or 3%, right? 2 or 3% overhead. and yet you have private insurance and private entities that run on 20% overhead, and you have CEOs making millions of dollars, and I can't see how a for-profit system in this city cannot aid and do more for the public service institutions like health and hospitals. And the other thing is that nothing can be done more that I see internally with H&H that will ever solve this problem. We need the resources from the city, we need the resources from the state. And yes, Washington, but if Washington doesn't do it, we live here, okay? We live here. And the state and the city, the mayor and the governor have to get together. And we have to demand that they get together, okay? And the mayor has stepped forward, I have to say. This mayor has stepped forward because back from the Dinkins days, when all the money was coming from tax levy into the H&H system, Giuliani and Pataki, the double whammy of privatization, cutting the funds to city funds to hospitals, and the cutting of Medicaid at the state level started a bigger downturn. And we need to change that mentality. It's public service. The last point is in terms of taking profit and fairness into the system. But the last point is some of us have been to the city council. 2 or 3 of us sometimes go into the city council hearings and testify. Maybe the state hearings. We visit legislators. Sydenham Hospital, there was a takeover by the community, and union people took over that hospital and set a tone. And Ed Koch said, I will never close. That was the biggest mistake he ever made. I will never close another hospital again, okay? And the thing is, we have to start having more grassroots people standing up and speaking at these hearings at the city council and in the city and the state and get people off the dime. Because otherwise, the public health system is not gonna survive. And there's not enough voices out there, okay? As to another voice, I'm sure.
Let me be that other voice. Judy Wessler, I'm the retired director of the Commission on the Public Health System, and still very actively involved. I recently was discharged from a public hospital rehab service, and am walking with a cane because of the excellent care. So anybody who thinks that you can't get very good care in a public system needs to go and visit and see. And you know, this is all about the politics of money, and I'm not talking about healthcare money. I'm talking about campaign money and who buys whom and what they buy. And unfortunately, that has determined a lot. The charity care dollars have not been moved to follow patients because of the private interests that make sure that it doesn't get changed. And that's, you know, Greater New York Hospital Association, 1199, et cetera, and so forth. So that politics of money has to be examined because we're talking about a whole system. We shouldn't just be focusing on the publics. The final thing I want to say is the importance of the safety net definition is that we need some standard of where money should go. Right now, the state has a definition that they did for the federal district money, which, you know, only 5 hospitals in New York City couldn't meet that standard, and we know that there are more than 5 hospitals that are not a safety net. And 2 of the ones that didn't meet it were Northwell, North Shore, and NYU. And they have very active involvement in the public system, which they're getting paid to do. So let's be clear about, you know, that is an issue and problem. The final thing I want to say is Jeff and I were involved in the St. Vincent's task force, and he actually gave a Tenants Association of a NYCHA project that I work with money to do, I'm sorry, that's my phone, to do, somebody's telling me to shut up. Jeff, I listened to you, you can listen to me, baby.
Take the whole night.
Thank you. So, so what I wanted to say is that there was $2,000 to do a survey of tenants in the NYCHA buildings, because there is some poverty in Lower Manhattan, The survey came up with some very good suggestions for that building with the round windows. And it included mental health services, geriatric services. That ain't what Northwell is doing at the Lennox, whatever it's called now, the emergency room. They're putting in services that make money and not responding to what the community identified, at least the low-income community in the area identified as needs. So they're, saying that the academic medical centers and the health systems are doing their part is a little not genuine. Thank you.
Judy, I think you should go back and get facts straight, because we said we weren't doing it in the building, but we did it in the community.
Yeah, where?
And I will show you where.
Okay.
We've developed
Go
primary
over
care, mental health, LBGT services. We'll go through it with you. But you don't seem to want to ever listen to what we do.
That's absolutely not true,
Okay,
Judge.
I'm just
Okay,
saying.
next.
Hi, my name is Valentina Jones.
Claudia.
I'm from the Lower East Side. I grew up in New York City housing. I went to Bellevue. I'm just going to state one concern. Well, let me just state this. One of the things on the Lower East Side, there's somewhat a rumor, and after I heard the rumor, I then kind of had the ability to look at certain things. That basically, you live in the projects, an ambulance comes to pick you up, you are going to Bellevue or below. You are not going to the hospital that's maybe 6 blocks further. My also understanding is that there's some sign in that emergency area that basically says you will not be staying here. You need to find someplace else to go. So I'm just saying that that's like, to me, one of the issues. But what I actually, so I needed to say that because that is like something that once I looked at it, it was like, yeah, this is where we're going from the Lower East Side. We are not going. And I think that if you look at the community health assessment, you will see that that hospital, that Bellevue, ZIP 102 is the highest populator of their clinics. And then if you look at this other hospital, that supposedly is taking everybody, that is not their statistics. Their statistics are something like they don't get that kind of statistics. They don't have a lot from 102 or 109 where people live in the projects. But my question actually is about, I read the report re-envisioning healthcare about health in hospitals. And to me, oh, wait a minute, let me just go back 1 second. See, my fear with all of this, growing up poor, is that these other hospitals, these voluntary hospitals, if we don't have health in hospitals, I think they will find ways not to take care of poor people. Because they know, I know from growing up poor, that my mother would have just walked out the door and said, okay, to whatever. And they know this. They know that when somebody is poor, when people grow up poor and feel unempowered, they are probably not going to complain about not getting services. They're probably just going to walk out the door. But my question, when I actually came to ask, was about re-envisioning healthcare. When I look at that report, it looks like we are looking at dollars and cents, and we are determining healthcare based on dollars and cents. And that's a Health in Hospitals report. And that's what it looks like. Utilization, underutilization, money. How much does this clinic cost, that clinic cost? How much does this one make, that one make? One of the things that I thought was extremely scary is that trauma care is expensive. And one of the things about Bellevue, I happen to be from the projects, et cetera, but I'm a retired registered nurse, and I have worked in Bellevue's emergency room. So I know the differences in emergency rooms. When I worked there, one of the beauties of Bellevue was the fact that the OR is like right there. And that's why you generally don't read that somebody died on the way to the OR Bellevue, because the trauma team is down there. They are waiting for the patient if they tell us. So I don't care how much Bellevue costs, it's like we need that. But that report looks very dollars and cents. So I would ask you to comment on what exactly is the plan there, because it looks dollars and cents, and it looks like they're looking all over the city and what costs more money, that's going, and they're not going to be looking at what the community needs or the service provide, but how much does it cost. And that report looks very plain and straightforward to me. It is about economics. It is not about healthcare or the care of people, or as we've heard in here, people with less opportunity, that feel less empowered, that are much more likely to just take it and roll over.
Great. So I'm going to keep going with some no, well, we're really beyond time for answer. I think that it was
Let
a
me
great
just say
comment.
one very quick
I
thing.
just want one answer, something
Okay.
short from you
I'm
about
gonna say something,
envisioning-
so excellent comments, and thanks for them. Our mission to provide services to the underserved is the sacrosanct piece here. What we have to figure out is how to do it in a financially sustainable way. So what underlies it all is we want to be around to provide that trauma care at Bellevue, and nobody is talking about eliminating trauma care at Bellevue for as long as we can. We live in an environment of dollars and cents. We know we can do some things more efficiently and effectively. For example, just a big thing we're working on right now, and it's big dollars. Revenue cycle, I'm going to admit I didn't even really know what that meant before I started Health and Hospitals. I know, crazy. We do not access all the money that we are entitled to not from individuals, from insurance companies, because our processes are old and were based on the way we did things in fee-for-service, where we were just billing the state Medicaid for almost everybody. And now we have 150 plans, and we haven't changed the way we do things to actually get paid. So there are many things we can do that will increase the dollars that are available for patient services, but the mission is the core, and that's not going anywhere, we hope. That's what we're all working on.
Hi, Bob Henley, Chief Leader. Just a quick poll of the panel. We know 50% of New York City's health and hospitals budget comes from the federal government. To what degree is a malevolent dysfunction in Washington providing a unique opportunity to New York State to be a national leader and move robustly for single payer?
That's a good question.
We will.
I'm with you.
Sorry. I don't think you're going to get anybody
Okay.
arguing with you.
We have just spent an hour talking about the problem when you're dependent on government payers. You are suggesting we become increasing our dependency on government payers, which will increase government bureaucracy, micro-regulation, and will not meet the cost of providing care to providers. As much as I am, as a person, I want to make sure everybody in this country has a right to health care, and we have to figure out how to do it. I am not sure single payer is the panacea that everybody thinks it is, because of the situation. I think some of the dysfunction in government and my fear of increased regulation and micromanagement, which will, I think,
We are the
exacerbate
only
problem.
country in the world that
right.
doesn't have universal health care,
that's
and we're
why-
defending it?
Wait, no,
Yes.
no, I'm not defending
and
it. You didn't hear what I said.
But-
We need universal health care. I'm not sure single payer is the process by which you
Well,
achieve it.
I have
Medicare has worked.
Thank you.
Well, it could be Medicare for
Medicaid
all.
has worked.
It could be Medicare for all. It could be
Well,
Medicaid.
which is another name for single payer. I sit here and I remember I'm 8 years old, 1965, and my grandfather said he was voting for Johnson because Medicare was going to be passed, if he became president. He said he wanted health care for me when I reached his age. But he also talked about how he wished that health care was there for everybody under that same framework. So the point is that Medicare for all is single payer, all right? And it's just like ACA, Obamacare, it's ACA, all right? Social Security Act doesn't have FDR's name attached to it, all right? It's ACA, all right? And he did a lot of work, but it's used in a negative tone. We have to give that former president in my opinion, tremendous amount of credit for the work that he helped orchestrate to get ACA across as a first step towards, in my opinion, to a single payer framework. But, sorry, but that's it. That's it. Thank you.
Brief comments, and then we'll wrap it up, and people can talk
But,
informally.
but can I just mention one quick thing? We need regulations, because that's how the stock market dropped in 1929.
And 2008.
Yeah, thank you. Yeah, okay, I was thinking my grandfather.
Hi, everybody. I'm Marlene Zurak. I feel like this is kind of like a meeting, and I am a recovering member of the Health and Hospitals Corporation. And it was my privilege to have spent 15 years with the largest minority-owned and operated organization for the benefit of people of all races, national origin, etc. It was my privilege to listen to meetings where doctors said, finally, I can work somewhere where I can practice and I can prescribe the correct medication for my patient without having to ask them, will you be able to fill this prescription? We started today on the premise that there is an essential need out there. And I want to start by asking the panel this question. How are we going to provide services for the mentally ill in New York City? Correct. The mentally ill who either were born without means or because of their mental illness could not retain the kind of jobs in the kind of environment where their families could not support them. How are we going to do that? How are we going to make sure that people on Medicaid can have babies in hospitals in this city? Okay? How are we going to make sure that people have access to primary care? These are kind of the very, very basics. Without HHC, it's going to be very challenging for this city. And it's not private business that's just going to step up and suddenly take care of people. Private business does not do things without getting paid. Only HHC does things without getting paid. Only HHC hires a nuclear waste company to deal with Ebola waste for millions of dollars on the promise from somebody in City Hall that, yes, someday we might pay you back for this, right? Only HHC deals with calamity and catastrophe, setting up and standing up new programs in a minute when the various mayors of the city call and say, I need this. The others will say, what are you going to pay me? How can you get it for me? Et cetera, et cetera. So how is this city going to survive without those services?
Wow. My name is Aida Gonzalez. And I am a member of CAB at Elmhurst, which is Community Advisory Board at Elmhurst Hospital. However, I'm here not in any official capacity. I'm here just representing myself with my own views. And of course, my concern has to do with underinsured and particularly immigrant populations. Now, the governor says and the mayor says that we are a special city where we protect everybody. We are a sanctuary city. But I have never been asked whether I want to live in a sanctuary city. There has never been a referendum about any such thing. Should we have a public consultation about that? Will that be something that could help us in terms of Washington? Am I seeing things very negatively? What is the relationship in terms of underinsured immigration or immigrants and the strains that our public hospitals are suffering? That is my question.
Mm-hmm. One more, and we'll, one more comment, and then we'll have a wrap up.
I'm stimulated to talk because of the last expression on single payer. We seem to have the location of hospitals, voluntary or public, and clinics and whatnot, determined by big real estate rather than where it should be located. Correct. I also grew up in Southeast Queens and Southern Queens. 1 million people have a great distance to go within Queens to get to 2 hospitals. Where is there a city of 1 million people on the planet with 2 hospitals? So I think that that's a big issue, that we should not have the determination made by an interested group in real estate speculation. The hospital down the block that closed had a brand new state-of-the-art emergency room that never opened. The one that is being shrunk and disappeared, that's in this direction, 6 years ago completed a complete remodeling of their emergency room over there, which I could tell you, having seen it in both states, was like night and day. This is being done not by need, it's being done by the value of the property. And I think that's a very important thing that has to be considered. Thank you.
Thank you. Any closing comments? No? We really are over, so brief if you are. Well, thank you very much for coming, and thanks to the panel, thanks for New School.
Andy, nice to see you
And thanks to the authors. Thank you. Thank you.